Honorable Principal, Honorable Director, respected Vice Principal Sir, respected teachers, my senior and junior colleagues. Assalamu alaikum and good morning. Welcome you all to the scientific seminar organized by Department of Microbiology. Today our title is A Global Public Health Emergency. The seminar will be chaired by Professor Dr. Zohra Begum, Professor of Microbiology, and the topic will be presented by Dr. Rufsana Afrin Rima, Lecturer of Microbiology. Now I request our chairperson ma'am to come on dais and conduct the rest of the session, please. Thank you all.
Honorable Vice Principal Sir, respected teachers, my beloved intern doctors and learned audience, Assalamu alaikum and very good morning. Welcome to our today's weekly seminar on behalf of Microbiology Department. Today our seminar on a global public health emergency. Earlier this month, the World Health Organization declared the Mpox is a global public health emergency due to the emergence of a new variant of the virus which is more virulent and easily transmissible. It is being now considered a potential pandemic. Our today's speaker, Dr. Rukhsana Arifin, she graduated from this institution in 2022 and now working as a lecturer of microbiology department. Now I request Rukhsana Arifin to deliver her presentation before the audience.
সেমিনার শুরুর আগে আমাদের এখানে দুইজন বিরল ব্যক্তিত্ব উপস্থিত আছেন যারা গতকাল পর্যন্ত আমাদের গেস্ট ছিলেন, কিন্তু আজকে থেকে ওনারা দুইজন আমাদেরই একজন। এর ভিতরে আমি পরিচয় করে দিচ্ছি আমাদের প্রফেসর চিত্তরঞ্জন দেবনাথ, এবং প্রফেসর ডাক্তার মোহাম্মদ হাবিবুল্লাহ, আমাদের আইএস প্রফেসর।
Honorable Vice Principal Sir, respected teacher, and my dear colleagues and my beloved intern, Assalamu alaikum. Welcome to all weekly seminar on global health, public health emergency. With the permission of my honorable chairperson, I would like to conduct my rest of the session. A global public health emergency. Monkeypox. Human monkeypox is a viral zoonotic disease caused by the monkeypox virus and has become the greatest public health threat in the genus orthopox virus after smallpox was eradicated. The symptoms of monkeypox virus infection are similar to that of smallpox, but in a milder form and with lower mortality of 1 to 10% in contrast to 30% for smallpox. Picture showing history and outbreaks, countries with Mpox cases. The monkeypox virus was first discovered in Denmark in 1958 in monkeys kept for research. The name monkeypox originated from this initial discovery. The first case of monkeypox virus in the human population was reported in 1970 in the Democratic Republic of the Congo in a 9-month-old boy. Mpox infections remain an endemic disease of the African continent, with sporadic cases diagnosed in forested regions of Central or West Africa and small-scale outbreaks until 2003, when the first cases of infection were reported outside Africa in the United States. There was not any report of monkeypox for several years, until the monkeypox outbreaks occurred in Nigeria in 2017 to 2021 and Cameroon in 2018, Moreover, since 2018, monkeypox cases have been reported in 109 locations, including 102 non-endemic countries and territories such as the United Kingdom, Israel, Singapore, and the United States, mainly from travelers infected in Nigeria. In fact, between 2010 and 2021, the number of monkeypox cases had increased at least tenfold compared to the 1970s. From endemic in Central and West Africa, the clade 2 strain caused a multi-country mpox outbreak in 2022, which spread mainly via sexual contact, has led all health organizations to declare it a public health emergency of international concern. In 2023, a new strain of the clade 1 variant was discovered in the country, known as clade 1b. African countries are reporting both clade 1 and clade 1b strains. Clade 2 is believed to cause milder infections. The fatality rate is 0.2% compared with 3.9% for clade 1. As of August 2024, more than 17,000 cases have been reported, with 591 deaths, nearly all in the Democratic Republic of the Congo. A new, potentially more deadly strain of the virus, clade 1b, is rapidly spreading within Africa and has been discovered in Asia and Europe. This triggered the World Health Organization to declare it once again a public health emergency of international concern or public health emergency on 14th August. So far, 4 countries, Sweden, Thailand, Philippines, and Pakistan, have reported mpox cases outside the African continent. Picture showing where has monkeypox has been detected. Important properties mpox virus. Enveloped double-stranded DNA virus. Family pox viridae, genus orthopox virus, species monkeypox. Virus types. There are two types of monkeypox virus, clade 1 and clade 2. Clade 1 with subclades 1A and 1B causes more severe illness and deaths. Some outbreaks have killed up to 10% of the people who get sick. Clade 1 is endemic to Central Africa. Clade 2 with subclade 2A and 2B is the type that caused the global outbreak that began in 2022. Infections from clade 2 mpox are less severe. Clade 2 is endemic to West Africa. Picture showing countries known to be endemic for clade 1 and clade 2 mpox. Source of mpox virus. The exact source of mpox in nature is not known, but it is believed that small mammals such as roe and sun squirrels, Gambian giant paused rats, and African dormice may carry the virus in parts of West and Central Africa. Small mammals can carry the virus without symptoms, while non-human primates like monkeys can get sick with mpox and have signs of disease like humans. Picture showing the source of mpox virus. Transmission of mpox. Human to human transmission. Mpox can be transmitted from one person to another through contact with infectious lesions material or fluid on the skin, in the mouth, or on the genitals. This includes touching, close contact, and during sex. The virus can also spread during pregnancy to the fetus, during or after birth through skin to skin contact. It may also spread by means of respiratory droplets produced by talking, coughing, or sneezing. There is a lower risk of infection from fomites such as clothing or bedding, etc. The virus enters the body through broken skin or mucosal surfaces such as mouth, respiratory tract, or genitals. Animal to human transmission. Via physical contact with an animal which carries the virus, such as some species of monkey or a rodent like a tree squirrel, may also develop mpox. Such exposure can occur through bites or scratches or during activities such as hunting, skinning, trapping, or preparing a meal. The virus can also be caught through eating contaminated meat which is not cooked thoroughly. Human to animals. Since many species of animals are known to be susceptible to the virus, there is the potential for spillback of the virus from humans to animals in different settings. People who have confirmed or suspected mpox should avoid close physical contact with animals, including such pets as cats, dogs, hamsters, as well as livestock and wildlife. Picture showing mode of transmission of mpox virus. Pathogenesis of mpox virus in human. After entry into the body, the virus replicates at the inoculation site and in the local lymph nodes. Primary viremia leads the viral spread towards other organs, like the liver and spleen, and replicates. Early clinical features start at this stage. When the secondary viremia takes place and the virus is transferred towards the cutaneous parts of the body, then mucosal and other lesions develop. The molecular diagnosis is possible from the stage of primary viremia until the pustule formation. The antibody immunoglobulin M can be detected when the secondary viremia starts till the lesions are resolved, whereas the immunoglobulin G can be detected from the third week of infection till a year depending on the patient's immunostatus. Viral shedding can happen with the beginning of clinical symptoms. However, the risk period of viral shedding is the vesicular and pustular stages. In this picture, virus enter into our body through skin scratches or mucosal surface of mouth, respiratory tract, or genital tract. Then it replicate in the local regional lymph node. Then it enter into the blood through thoracic duct, and this called primary viremia. After the end of primary viremia stage, the clinical symptoms are appear. Then it again replicate in the other organ like liver, spleen, and kidney. Then it again enter into the blood, and in this stage is called secondary viremia. Then virus localized to the major target organs and develop the pox-like lesion. Then the whole condition gets resolved. Immunopathogenesis of mpox. Monkeypox virus impairs natural killer cell function and reduces secretion of gamma interferon and tissue necrosing factor alpha. Directly damage immunoorgans, including thymus, tonsil, spleen, and lymph nodes, thereby leading to lymphopenia. Evades the innate immunoresponse via suppressing the antiviral type 1 interferon response. A neutralizing monoclonal antibody can promote virus entry into cell. This is correlated with disease progression and poor outcomes of patients with monkeypox. The cytokine storm caused by monkeypox virus infection is associated with a prominent helper T cell type 2 immunoresponse and attenuation of helper T cell type 1 associated cytokines, such as interferon alpha, interferon gamma, tissue necrosis factor alpha, interleukin 2, and interleukin 12. Immunoglobulin G and immunoglobulin M levels are also elevated, and there is a higher titer of total antibodies. Inhibition of the host complement system. Picture showing the immunopathogenesis of mpox. Clinical manifestation. Signs and symptoms. Monkeypox symptoms usually start within 3 weeks of exposure to the monkeypox virus, typically lasting for 2 to 4 weeks. Often the infected individual develops flu-like symptoms. Fever, headache, muscle aches, backache, and fatigue are the typical initial symptoms. After the onset of fever and lymphadenopathy, rashes appear 1 to 3 days later. The infection can be transmitted from when symptoms start until the rash has healed. The significant distinguishing difference between monkeypox and smallpox is the timing of lymph node enlargement that often occurs early at the onset of fever. Fever often subsides on the day of or up to 3 days after rash onset. The lesions are more localized on the face in 95% of cases, palms and soles in 75% of cases, oral mucous membrane, extremities, genitalia, conjunctiva, and cornea. The rash will go through several stages before healing, including papules, vesicles, pustules, umbilicated pustules, ulcerating lesions, and scabs. The infection can last up to 4 weeks until the lesion peels off. Picture showing stages of skin rash. Stage 1 macules, Stage 2 papules, Stage 3 vesicles, Stage 4 pustules, and Stage 5 scabs. Picture showing rash appear in the different part of the body. Risk of severe disease. Although cases of mpox are not life-threatening, some people may be more likely to get severely ill, including people with severely weakened immunosystems, children younger than 1 year, people with a history of eczema, people who are pregnant. Complication of mpox. Mpox complications can include severe scars on the face, arms and legs, blindness, neurological, seizures, encephalitis, heart, myocarditis, secondary bacterial infections, death in rare cases. Laboratory diagnosis of mpox. Monkeypox is generally not clinically distinguishable from other pox-like virus, and clinical observation alone is insufficient for diagnosis. Therefore, repeat laboratory diagnostic methods are crucial for the clinical management, along with limit the outbreak. Specimen. Skin lesion material including swabs of lesion surfaces and or exudate, bruise from more than one lesion or lesion crusts, and serum. Method. Electron microscopy, culture of material from rare specimen, RT-PCR assays, serological testing for specific antibodies. But confirmation of monkeypox virus infection is based on nucleic acid amplification testing using real-time or conventional polymerase chain reaction for detection of unique sequence of viral DNA. Serology of mpox. Serological tests provides evidence of virus exposure. They have limitation due to cross-reaction with other orthopox virus. Detection of immunoglobulin G and immunoglobulin M antibodies by ELISA. Immunoglobulin M is detected in serum about 5 days after the onset of rash, whereas immunoglobulin G is detected more than 8 days after the onset of rash. The presence of both immunoglobulin M and immunoglobulin G in a sample is strong evidence of recent exposure to orthopox viruses in patients who have been previously vaccinated or exposed to the infection. Treatment and prevention of mpox. Treatment for most people with mpox is aimed at relieving symptoms. Care may include managing skin damage from the mpox rash, drinking enough liquid to help keep stool soft, and pain management. There is no specific treatment approved for mpox. Healthcare professionals may treat mpox with some antiviral drugs used to treat smallpox, such as tecovirimat and brincidofovir. Prevention. Take these steps to prevent infection with or the spread of the mpox virus. Avoid close contact with people who have a rash that looks like mpox. Avoid handling cloths, sheets, blankets, or other materials that have been in contact with an infected animal or person. Isolate people who have mpox from family and pets until rash and scabs heal. Wash your hands oil with soap and water after any contact with an infected person or animal. If soap and water are not available, use an alcohol-based hand sanitizer. In countries where animals carry the virus, any food containing animal parts or meat should be cooked thoroughly before eating and getting vaccinated. World Health Organization recommendation on vaccines and immunization for mpox. Mass vaccination is not required nor recommended for monkeypox at this time. Pre-exposure vaccination recommended for individuals at high risk of exposure such as health workers, men who have sex with men, people with multiple sex partners, sex workers, laboratory personnel. Post-exposure preventive vaccination Recommended for contracts of cases ideally within 4 days of first exposure and up to 14 days in the absence of symptoms. Mpox vaccines. At present, all health organizations recommended use of MVA-BN or LC16 vaccines or the SCM 2000 vaccine. MVA-BN, modified Vaccinia Ankara Bavarian Nordic, is a non-replicating attenuated live virus vaccine that is incapable of replication within human host. This vaccine administered subcutaneously in a two-dose series 0.5 ml per dose 4 weeks apart for prevention of smallpox and mpox. Vaccine efficacy ranged from 36 to 86% for one dose and increased to 66 to 89% 2 weeks after administration of the second dose. People are considered fully vaccinated about 2 weeks after taking their second dose of vaccine. Conclusion. Monkeypox infection was endemic in Central and West Africa except for a large outbreak in the United States in 2003. Several outbreaks in non-endemic countries have occurred in the past 5 years, raising concern regarding a global pandemic. Developing rapid laboratory diagnostic method, specific vaccines, and therapies for the prevention and treatment of monkeypox infection should be a part of the effort to limit the outbreak. In the current monkeypox outbreak, there is a big concern about human-to-human transmission to household members and care providers. Considering the pandemic burden, the public health importance of monkeypox disease should not be underestimated.